joining us for tonight's event. I realize now, so the event is called The Right to Die, but I need to say question mark because there's a question mark in that. So The Right to Die, a debate on physician-assisted suicide in Ohio. My name is Jonathan Kolp. I am the director of the Institute of American Constitutional Thought and Leadership here at the University of Toledo. And I just want to say a few opening remarks before we get started with the debate proper. So the Institute, okay. All right, so the Institute was created by the Ohio legislature in 2023 as an academic unit within the University of Toledo, and its mission is to strengthen the civic knowledge and civic capacity of students, but also of citizens by helping them to understand the principles of the American constitutional order and the great debates within the Western tradition and the American tradition that continue to shape that constitutional order. So we serve students at UT by offering courses and minors and a soon-to-be launched major in constitutional studies, and also by organizing various extracurricular academic activities. I wanted to mention also that we serve the regional K-12 community too by offering professional development for teachers in various forms. And I mention this in part because we recently received, or when the government opens up again, we will receive a substantial grant from the Department of Education for a 3-year program aimed at professional development through K-12 teachers. But part of that 3-year grant will actually be a series of conferences. There will be a conference each fall open to the public on that will be devoted to issues in American civic life. So if we'll be bringing in experts from all around the country, it'll be great. And so be sure to, if you haven't already, sign up for our newsletter so you can be kept apprised of that. But another essential part of the Institute's mission is to provide regular events for the citizens of Toledo and the broader region to help them become better informed about pressing issues in our society and about the constitutional principles that should guide our deliberation about those issues. And through our teaching, our research, through our programming, we also aim to model what it means to disagree intelligently and respectfully about difficult questions, especially the kinds of questions that go to the heart of what it means to live well together in a free society. And our debate today is one such event devoted to that. So I wanted to say a few words about the topic, because our topic tonight is physician-assisted suicide, otherwise known as medical aid in dying, a practice in which a physician provides a patient with the means to end his or her own life, typically through prescribed medication and under certain regulated circumstances, usually terminal illness, but not always. I would mention at the outset, just for the clarity of the debate, that it's important to distinguish physician-assisted suicide from euthanasia, related but different topic. In euthanasia, the physician directly administers the life-ending act, whereas in physician-assisted suicide, the final act is carried out by the patient. So you see they're overlapping, but not quite the same. Now, over the past 3 decades, both public opinion and the law in the U.S. has shifted considerably on this issue. In 1994, I believe it was, Oregon became the first state to legalize physician-assisted suicide under what was called the Death with Dignity Act, some of you might have heard of. Since then, 10 other states and the District of Columbia have enacted similar laws, allowing the practice under narrowly defined circumstances. But at the same time, strong moral, medical, and legal objections to the practice remain. And in the majority of states, including Ohio, physician-assisted suicide remains illegal. So this debate then raises profound questions. What's the proper role of medicine? How should society understand autonomy and compassion and the value of life? And to what extent and on what grounds should the law guide and limit end-of-life decisions? Very important questions. And that's what we'll be debating tonight. So here's how the event will proceed. Each of our 2 speakers will begin with a 10-minute opening statement, one presenting the case for physician-assisted suicide and the other presenting the case against it. After those statements, I will moderate a period of questions and discussions. To begin with, I have some questions that I'll ask. And then after that, we'll open the floor to questions from all of you. So you'll have time to ask questions too. And then finally, when there's about 10 minutes left to go in our allotted time, we'll go till about 8:30. Each speaker will have 5 minutes for closing remarks. And I'll offer a few concluding reflections. So again, our goal today is not to settle this question once and for all, but to illuminate it, to help us all understand more clearly the moral and civic dimensions of an issue that touches every one of us, directly or indirectly. Now, we are joined by two distinguished bioethicists who bring both scholarly depth and personal integrity to the discussion of this issue. We have, and this is not symbolic, but on the far left, I have Dr. Charles C. Camosy of the Catholic University of America and Dr. Jason Chen of the Ohio State University. Dr. Charles Camosy is an associate professor of moral theology and ethics at the Catholic University of America. His work bridges theology, moral philosophy, and pressing challenges of contemporary bioethics. He's written several books, including Living and Dying Well, a Catholic Plan for Resisting Physician-Assisted Killing, and Resisting Throwaway Culture, How a Consistent Life Ethic Can Unite a Fractured People. Dr. Camosy also writes frequently for various national venues, engaging broader public audiences in moral reflection. Dr. Jason Chen is a postdoctoral researcher in the College of Pharmacy at the Ohio State University. He's also a senior lecturer in philosophy at the University of Akron and is a certified healthcare ethics consultant. His scholarship explores complex moral questions at sort of the intersect, you could say, of clinical practice and philosophy, including topics such as consent, moral responsibility, and euthanasia. His article, Subsequent Consent and Blameworthiness, in the HEC Forum examines how consent given after an intervention affects moral judgment. And his more recent writings, such as Pet Euthanasia and Human Euthanasia and Voices in Bioethics, probes the boundaries of compassion, agency, and moral consistency in end-of-life decisions. So please join me in welcoming Dr. Charles Camosy and Dr. Jason Chen. Now, since this is a debate, there is the formal resolution we're debating is resolved. Physician-assisted suicide, or medical assistance in dying, should be legal in the state of Ohio. Since physician-assisted suicide is currently illegal, that means that Dr. Chen is arguing for the change to the status quo, and that means that he gets to go first.
Can I pace here?
Yes, you can pace all you want.
I like pacing. Thank you, everybody. I'm honored to be here. So the arguments in favor of legalization of assisted suicide are quite straightforward. The first one is autonomy, and the other one's well-being. Okay? So what do we mean by autonomy? Autonomy is referring to a person's autonomous choice, okay? In particular, medical choice, right? All right, but what does that mean? Generally, it means that the choice is informed, it's voluntary, and the patient has what's called decision-making capacity, okay? So this is a technical term. Decision-making capacity is constituted by 4 subcapacities. One is understanding the relevant information, okay? The second is appreciating the situation, right? The third is reasoning between different treatment options versus non-treatment. And then the fourth is communicating a choice, okay? You have to possess all 4 to possess decision-making capacity. The reason why I bring this up is because it's a very important concept that's operationalized in medical decision-making, because patients generally have the right to refuse medical care, including life-saving care, okay? That is your right, if you have decision-making capacity, all right? So one of the important tasks that doctors have at the hospital is to determine if you have decision-making capacity or not, okay? If they're not entirely sure, they may page ethics, the clinical ethics consultation service, right? They kind of come in and kind of, assess the situation and help out. They may page psychiatry to come and assess the patient's decision-making capacity, okay? So let's say that they deem that the patient lacked decision-making capacity. At that point, medical decisions are made in conjunction with your surrogate decision-maker, okay? So it's a very important assessment to make, because there's a fork in the road, right? Either you have the authority to make your own medical decisions, right? Or you don't, and we go with your surrogate, okay? So that's generally the idea of autonomous choice. So since people have the right to refuse care, including life-saving care, right, and we honor that due to respect for your autonomous choice, the same argument would apply to something like assisted suicide, right? You can be informed, you can make it voluntarily, and you can have decision-making capacity for that choice as well. So that's the autonomy side of the argument. Okay, so now the well-being side. Essentially, it comes down to that death can be in someone's best interest. Sounds kind of weird, but kind of not. Okay, because you're essentially saying, or the proponents are saying, that death can be good for you. Right? Again, sounds a little weird. Right? I think an intuitive way to think about it is in the case of our pets and pet euthanasia. Right? The idea is that there is such a thing as suffering, and it's possible that your future is characterized by more suffering than it is with positive experiences. Right? And if that's the case, then death would be good for you because it deprives you of that future suffering. Right? If death deprives you of future well-being, like overall well-being, then death is bad for you. Okay? So that position is called deprivationism, right? Because it just, whether or not death is good for you depends on what it deprives you. Okay? Deprivation, I'm a deprivationist. I think it's quite intuitive as a theory. It explains why we generally think it's worse when children die, right? Versus somebody who's already at the end of their life, because a child is going to be deprived of that future. Okay? We think about this in the terms of pets. I think it's quite intuitive. And usually people, even who are against assisted suicide, are okay with pet euthanasia. Right? So then, that argument from well-being, the proponents think, also apply to human beings. If a human being's future is characterized by more overall suffering, then death is going to be in their best interest. Hence, death is not a harm. To cause death to that person does not constitute a harm. Right? In fact, it is a good thing for them. It might be bad for the family because they might be sad, but it would be good for that person. So that's kind of the well-being argument. Okay? These two arguments combined, I think, provide a strong justification for why we should honor people's informed refusals of medical care. Okay. And so I think those two arguments also apply to assisted suicide. And throughout this discussion, you'll see me jump back and forth between those two contexts. Assisted suicide on the one hand and refusing life-saving care on the other. Proponents generally don't see a moral difference between the two. Okay? Some people who are against assisted suicide do see a moral difference between the two. Right? I think there's a conceptual difference, but not a moral difference that maps onto the conceptual difference. If that makes sense. Yeah. So those are the in favor arguments.
Okay. Thank you very much.
I have to say, people that are able to get up like Jason and speak without notes kind of intimidate me a little bit. So I'm gonna do my best here with my notes, if that's okay. First of all, thank you for coming this evening. Thank you for the invitation. We had, for those of you who were here last night, you know we already had a very good exchange, preliminary exchange last night, and just really grateful for Jason's winsomeness, engagement, as a philosopher, being willing to engage a moral theologian as well, right? That's an open-minded person right there. But thank you all for coming too, because I think it's probably not lost on any of us the current moment before us in the culture, especially in light of recent political violence over the last some time. But I think this topic in particular should give us some hope. At least I don't see this at all along a kind of right, left, red versus blue fight to the death. In fact, there are some pretty significant progressive or blue states that have rejected it. There are some who have accepted it, of course. But there are, right-wing conservatives and libertarians that support it, and there are progressive Democrats and liberals who are against it. And last night, I think it was pretty clear we had some very significant disagreements, and we're going to explore those today, but I think it's fair to say we definitely have some overlapping agreements. Let me set my timer here so I don't go too long. I want to start by thinking about data. So I am not a data person. I'm a moral theologian. I think I'm somewhat educated on the data, but at least as far as I can tell, we don't have a lot of good data. For instance, the state of Washington recently said we're going to stop essentially keeping track of this, which was built into legislation when they passed it, because of budget cuts, which seems almost literally unbelievable that that would happen, right? Because of budget cuts, we're going to stop keeping track of. I guess it costs something for oversight and that sort of thing, but I guess that's the first thing I would say is I hope that what we can do into the future is really hold states accountable for getting the good data so we can have a really super informed debate on these questions. But I at least want to argue 4 different things this evening. The first is that, can I just say PAS instead of physician-assisted suicide every time? PAS violates the intrinsic dignity of the human person. PAS helps shift our understanding of what lives are valuable and which lives are worthy of protection and public support, especially in the face of scarce resources, which puts the most vulnerable at risk. PAS, when legalized, takes on a logic of its own that goes well beyond the original intention, and in my view, to truly diabolical places. And PAS, when understood as healthcare, undermines the very nature of any coherent understanding of a profession or practice of medicine geared towards certain ends. And apparently I'm going to do that in 8 minutes, so let's see if I can pull that off.
We can elaborate too.
Okay,
with the rest.
yeah, we
That's
can
fine.
go through.
Yeah.
So PAS violates the intrinsic dignity of the human person. I'm pretty sure Jason rejects the premise, in part because it's religious, but I think this intrinsic dignity of the human person comes from being made in the image and likeness of God. And this is in the very foundation of our country, right? The Declaration asserted that we're endowed by our Creator with certain unalienable rights. And it's on this basis we've said that there is such a thing as human dignity and fundamental human equality. And though we haven't always lived this out, people like Martin Luther King Jr., the Reverend Martin Luther King Jr., who, by the way, was a systematic theologian, got his PhD at Boston University, explicitly thought we need to invoke this theological concept for his understanding of civil rights. And so I hope I can put myself in that kind of company here when I say this is the foundation. That's not to say that others can't get on board. There are groups like Secular Pro-Life. There are, of course, philosophers that appeal to the natural law. But I think what we're really on here is something like human dignity, which means that there are certain actions which are wrong without exception based on that dignity. So sexual violence, torture, aiming at the death of the innocent, selling yourself into slavery, selling your kidney on an open market to the highest bidder. Autonomy, though it is one value, it's one among many values, and it's a value which is already limited in profound ways. And it's something I think we ought to limit when it comes to physician-assisted killing or physician-assisted suicide, because, in part, we already do it for suicide in general. Sometimes literally, as you see in this photo, wrapping yourself around a person, violating not only their autonomy in principle, but their bodily autonomy, their ability to even move, right? And this is considered a heroic action. I was talking to one of my friends who teaches at the University of Michigan Medical School, Dr. Kristen Collier, about this debate, because she debates this regularly, and she wrote to me, still to this day, if someone presents to me with suicidal ideation, I can override their autonomy and hospitalize them, because we still believe that would be a tragedy. Moving right along, let's talk a little bit about how PAS shifts our understanding about what kind of lives are valuable. I think a really important insight is just how often those who request it are the most privileged, overwhelmingly wealthy, overwhelmingly white, in fact 90% white, overwhelmingly college educated. So it's not people who very clearly know that they don't have autonomy. It's not people who very clearly understand that they are coerced in many structural ways. It's generally our most privileged people who want to take advantage and do take advantage of these of physician-assisted killing. Now, one of the things that I think is so interesting about this, oops, did I skip one? No. Yeah, here's what I wanted to get to. Canadian public opinion it's so interesting. We think about the ways in which physician-assisted killing, in my view, has shifted the culture. I don't know if you can see it on this chart or not, but I can interpret it for you. If you can see, do I have a laser pointer? I think I do. You can see this is, at this point, only adult with a grievous and irredeemable medical condition can seek assistance in dying in Canada. Do you agree or disagree with allowing adults in Canada to seek assistance in dying because of the following reasons? Poverty. 18 to 31 years old, strongly agree, 16%, moderately agree, 25%. 41% of 18 to 34-year-olds in Canada either strongly or moderately agree that poverty alone can be a reason why one would request this. And I'm going to go, and I have an out of order slide, I guess, here. It's unsurprising then with these kind of attitudes that we don't do as much for these populations. I have a slide here about hospice and the situation in the United Kingdom, where hospice resources are apparently being made more scarce. It's not causation necessarily, but certainly correlation to say this is happening just as the House of Commons has legalized physician-assisted killing in the United Kingdom, and it looks like the House of Lords is probably going to pass some version of it, though they may try to limit it in some capacity. Netherlands has, to their credit, tried to increase palliative care resources, but at least in the research I did even just a few hours ago, it looks like they're struggling to get patients to use those resources, something which suggests to me that the PAS mindset has been taken over there. And then if I could just read a little bit from an article of what's already underway in Canada, 2022 article. Dr. Leonie Herx, head of palliative care at Queen's University in Kingston, Ontario, and immediate past president of the Canadian Society of Palliative Care Physicians, testified April 25th, 2022, that only to 30 to 50% of Canadians who need palliative care have access to it, and only, quote, a very few, or about 15%, have access to specialist palliative care. Quote, when patients' palliative care needs are not met, the ensuing physical, emotional, and spiritual suffering can lead them to feeling depressed, hopeless, and a burden to others. Many of the factors driving requests for MAID, Herc said. Earlier palliative care can alleviate suffering before it becomes irredeemable, end quote. Quote, with almost 6 years of lived experience now, we have seen significant deleterious effects of MAID implementation on palliative care, including diminished resources and increasing distress experienced by palliative care physicians, Herc said. Last paragraph. Quote, there is an increasing moral distress in palliative care clinicians from forced participation in MAID due to some health authorities mandating that MAID be provided in hospitals and palliative care units or lose funding, she said. This is resulting in retention difficulties and early retirements from palliative care, which is accentuating and accelerating the already critical shortage of specialists and general palliative care physicians, end quote. All of this saves money, of course. And I think it's no accident we're starting now to see PAS connected with organ donation to give patients a sense that something good can come of their lives. I'm going to have to go quickly for the last two. Let's go to the next slide here. Here are 4 examples, I think, of logic, taking the logic that goes beyond the original intention dementia at family's request, women, be quiet, women in public housing with chemical sensitivities, eating disorders, sexual abuse. Those are the 4 examples I have on the board. You could go beyond that. People who want a wheelchair ramp, people with PTSD from war, people given the wrong mattress and having a bed sore with exposed bone. These are all examples of people who've been approved for so-called medical aid in dying. And we're not there yet, but the Canadian Government Commission on this topic wants to explore the option for mature minors to be able to request it without their consent. I could say more about that, but I'm going to power through and just go to 4. This is a slide that shows a recent result from the American Medical Association, which very clearly in their code of ethics reaffirmed the position that physician-assisted suicide is fundamentally incompatible with the physician's role as healer, which would be difficult or impossible to control and would pose serious social risk. This was passed overwhelmingly just very, very recently. In fact, it was June 6th to 11th of this year. 700 delegates overwhelmingly reaffirmed that. They also strengthened conscious protections for physicians in states where PAS is legal, allowing them to opt out without professional repercussions. And they also explicitly rejected an attempt to change the language from physician-assisted suicide to medical aid in dying, because they understand that once killing becomes a part of medicine, you lose any coherent concept of medicine. So I'll stop there.
Thank you very much. So I think we have many issues that have been put on the table. There are a few questions I'd like to ask before we open things up to the audience. And to begin with, Dr. Chen, you had invoked the principles of autonomy and well-being as sort of the joint or the 2 bases for the defense of physician-assisted suicide. And Dr. Camosy, one way of taking some of your remarks is that you responded to those 2 principles on the one hand by saying that we limit autonomy in all sorts of ways, and this is one area where autonomy should be limited, and also that above any concern for well-being, there should be a concern for the intrinsic value of human life. So, Dr. Chen, I'd like to give you a chance to respond to those claims, to the claim that we do limit autonomy in areas. So what is the argument for making autonomy a guiding principle in the case of this decision? And also the question of the intrinsic value of human life versus considerations of well-being. And you can take it in either order.
Yeah. So let me take let me address the first one first. Okay. So physician-assisted suicide violates the intrinsic dignity of the human person. That concept. Okay. First of all, for those of you who don't know, intrinsic value is often contrasted with instrumental value, right? So something has instrumental value if it can get you something else that's valuable, right? So something like money, right? It's only valuable because it can buy you stuff, right? Intrinsic value means that that thing is valuable in and of itself. It's not valuable because it can get you something else. That's what that means. So I think I would need a better understanding of what intrinsic dignity means. So the way that I understand it is in terms of intrinsic value, right? So this human being is not valuable because this human being contributes to our economy, right? They're valuable because they are a living human being in and of itself. Would you agree? Is that correct?
Because human nature bears the image and likeness of God.
Okay. Do you think that there's a secular version of that?
No.
Okay. So that means you don't think that like non-human animals have this intrinsic dignity because they're not made in the image of God.
Unlike some Christians, I take the animal question very seriously. In fact, I wrote a book called For Love of Animals, and I think it's a very serious question. Animal rights, animal concern. And I'm actually willing to argue that maybe there are some non-human, we already know in our tradition anyway, there are non-human persons. that would have something like intrinsic dignity. So angels, for instance, non-human persons. I sometimes invoke Frodo Baggins to my students or something like this, right? Non-human person. If we met aliens, which throughout basically the Middle Ages, since the Middle Ages, Catholic theologians have been thinking about persons on other planets, the possibility of that. And I'm at least willing to talk about dolphins and elephants and very sophisticated creatures like that. But I would say that human beings reflect God's image in a way that's different than non-human animals, at least as far as we know. Yeah.
Okay, but is that based on the fact that we're the rational animal? Is it rationality that's doing the work there?
Capacity to know and love God is how the tradition tends to think about it.
Capacity to know and love God. Okay, yeah. So I mean, I would agree that that would probably exclude non-human animals, at least the ones that we're familiar with.
Yeah.
Okay. So then, how does that connect to this concept of well-being? Because that's generally how I understand goodness. I understand things of like good for, like whether or not something is good for you or bad for you. Do you see that as just like a separate thing?
When I hear language like good for you, I think of the kind of instrumental concept that you mentioned before, and I don't see life as like that. Your life is not good or bad for you in that way.
Do you think
sort of a category error, I guess I would say.
Yeah, yeah. So I don't know if I want to say that my life is good for me. The way that I would phrase it is being alive. Like, do you think being alive is necessarily and always good? For the person.
No, I don't think there's an easy answer to that question. Yeah, in fact, for those of us who are Catholic, we just celebrated the Feast of St. Francis a few days ago. If you saw some animals around churches, you may have seen that was the Feast of St. Francis. And St. Francis, actually, at the end of the Canticle of the Creatures, Laudato Si, if you know anything about Pope Francis, he wrote this, Praise Be, this encyclical called Laudato Si. And the last part of St. Francis's Laudato Si is Laudato Si for sister death. Praise be you, God, for sister death. And so death is in some ways an evil, but in other ways it's complicated. So I wouldn't want to give it's not an easy answer to answer that question for me.
Yeah. So, like, what about a case where a person is just like going to suffer for the rest of their life? Like, do you think that death can be in their best interest?
Yeah, I think, I guess I would say it's complicated, right? So I don't think that's for us to take into ourselves, right, as individuals. But I think it's totally legitimate, and we see it all the time, that people pray God to take them, right, in those circumstances, and I think that's legitimate.
Mm-hmm. Yeah, so I would agree with that, and I think that that's generally how we think when it comes to our pets. So if we're willing to grant that death can be in someone's best interest, then I don't see that as a bad thing to necessarily cause somebody's death, right? So it can't, it also intentionally, right? So if I do something to you that benefits you, and I do that intentionally, that cannot be morally bad. That's where I'm coming from, right? Now, if you thought that death was always a harm to the person who dies, then you can justify some sort of general prohibition on causing the death of somebody innocent, right? But if you can see it as something that is good for the person who dies, then I think that prohibition kind of goes away.
And when I tried to articulate some exceptionalist moral norms, I was doing so in a way that tried to offer an alternative view to this. So I would say we can imagine a scenario where selling your kidney on the open market would be good for you, and it still would be intrinsically evil, right? Or selling yourself into slavery could be good for you in some kind of analysis, but it violates human dignity in a way that we ought not to allow anyone to do it. And in fact, it's morally prohibited in every circumstance. We could tell consequentialist stories about it being good for people to torture somebody, same sort of thing. So hopefully I can admit that we could tell a story about how it might be better for you without it also following that it would be right to kill you or to help you die.
Yeah. So I think like the examples that you gave, so I would, I think the slavery example and the kidney example are a little different. And the reason is because the slavery, like if you sell yourself into slavery, I'm assuming like for this example to work, that you would be unable to I guess like live out your autonomous wishes from that point on, right? So you're making perhaps you can tell a story how you're making an autonomous choice right now, but then that would violate your future autonomy, maybe, right? Right, because like let's say that you change your mind,
yeah.
right? Is like, well, I want to do this, and then the master says like you can't. So in that sense, it's yeah. So I think so that's one thing. The kidney example. I mean, I haven't read too much into the literature on selling of your bodily organs, but I think my general leanings is that, at least like tentatively, is that you should be allowed to do that, because it really does come down to autonomy, and what's packed into that notion is bodily autonomy, right? So this is going to be like one of the core questions that I think like people should think about, like who does your body belong to? Does your body belong to me? Should I be able to make end-of-life decisions for you? You know what I mean? So, and I would say no, right?
And then why can't someone sell themselves into slavery?
So that one's trickier because then you can't exercise your autonomous will beyond that point.
So we could make a law that would control someone's body in such a way that they can't sell themselves into slavery. If you wanted to do it, we would physically restrain you, maybe even put you in jail.
Yeah, I mean, those are tricky cases. I'm not entirely sure, and I would have to read more about the arguments like in favor and against. I'm just saying, like, as of right now, I see the two cases as kind of separate. But yeah,
Sorry,
yeah.
go ahead. It seems like we make autonomous choices to limit our autonomy all the time, right? Like, if I choose to get married to somebody, right? I don't have the kind of freedom that I had before. If I choose to take a particular kind of job, or if I choose to move to a particular kind of area, right? I could limit my autonomy in all sorts of ways.
Yeah, but that's like opportunity cost, right? So it's like if I had two options for jobs, and then if I take one, that I can't take the other one, right? Or if I marry this person, that I can't marry the other person. But it's not irrevocable in this sense, like how slavery is, because you can still change jobs, right? After that, and you can get a divorce, right? Whereas I'm assuming that if you sell yourself into slavery, you cannot get out of it. Like you're always in that position.
So it has to be really super duper limiting then. What's the standard we would use?
For I mean, for now, I would say, yeah. I mean, because for slavery, that would be permanent, right? That's a hypothetical.
I don't want to totally get bogged down on this.
Yeah,
well, no, but it's important though too, because death is permanent.
Yeah.
So if slavery is impermissible because it permanently prevents future exercise of autonomy, wouldn't that apply to choosing to kill yourself also?
Yeah. So that's a good point, and that would also apply in the case of refusing life-saving care, right? So here I'm going to go back and forth. If you think that you have the right to refuse life-saving care, you should be in favor of assisted suicide, right? So all I'm asking for is consistency. Maybe you don't think that you should be able to refuse life-saving care. Then okay, that's fine. Then we can have some other conversation.
This is important. Do you mind if we just talk about this
Absolutely.
for a little bit? Because I think this is a core disagreement between us. Or there's significant agreement though, I think. So let's talk about that first. The Catholic definition of euthanasia, which is not, we can talk about its relationship to assisted suicide, is an act or an omission which of itself or by intention causes death. So, and I think this gets overlooked quite a bit in people who are on my side of the debate. I think it's a huge mistake to limit this just to actions. One can aim at death by omission, and that's exactly the same kind of act. I sometimes use the example of it's a terrible example, but it makes the point of the husband who wants to kill his wife for the life insurance money, and he's about to drop the toaster in the bathtub, and he sees that she's drowning and just lets her drown, right? He aims at her death by omission. Is that different morally than whether he dropped the toaster in the water? I think most of us would say no, they're the exact same kind of act, morally speaking. But because omissions can also be something else, right? They could be, to use the principle of double effect, they can be things that you foresee would result in death or the speeding of death, but are really aiming at something else. So my father just died July 31st. I personally put tons of morphine into his mouth as he was dying, and it sped up his death. There's absolutely no question that it sped up his death. But I was not aiming at his death. I was not trying to speed up his death. you might imagine, given what I'm arguing for tonight. I was trying to control his pain. I was trying to participate in a hospice setting to control his pain. Similarly, we can also refuse to care for somebody, have an omission where we see that death is the likely result. This happens all the time by taking somebody off of life support or a DNR or something like that, where the aim is not death, even though we foresee death is the result. So I would say those are important distinctions to have, and because, okay, let me finish with this, because it's so complicated to sometimes figure out, well, what is happening in the omission, right? Are we in fact aiming at death? Are we not? And people have multiple intentions sometimes, so it can get really complicated to sort of figure out what is actually happening here. I can imagine somebody else in my situation with my father who injected morphine into his mouth, sort of having a complicated intention when he did it, right? Saying like, I don't know if maybe I'm sort of thinking about both things, right? And so for that reason, I think especially legally, we should have a lot more freedom and opportunity and like understanding of what's happening and say, well, when it's an omission, when we're foregoing care, we're just going to have a lot more latitude. Because when it's aggressive, when it's active, it's just almost totally clear that something like this is going on. Does that make sense? I'm at least trying to show how I'm thinking about this.
If you could just, you're trying to get at the morally significant distinction between the choice to refuse care, which you think should be honored, at least under certain circumstances.
It's just so hard to determine what somebody's intention is. Often, it's hard. And so I think there should be legal room for refusing care, refusing treatment, that we shouldn't give to aggressive killing.
Because of the motives that might enter into the...
Because it could be very well be legitimate.
Okay.
And often is legitimate to refuse.
Yeah, so I agree that the act versus omission distinction that's not really what's doing the work here. I think what's more doing the work is the person's intention, right? So I think suicide is intentional self-killing, right? So in cases of refusing life-saving care, I think oftentimes they're not intentionally trying to hasten their death, right? So the intention may be, well, I just don't want this particular treatment because the burdens outweigh its benefits, right? Death is hastened and that is foreseen, but that's not the intention, right? So that's totally true. However, even in the cases where hastening death is the intention, I think they should be allowed. All right, and I know there are cases there where I would agree that we're not entirely clear what the intentions are, and I'm saying that even when we are clear of what the intentions are, and the intention is to hasten their own death, that via refusing life-saving care, that it needs to be honored. So he also brought up something called the doctrine of double effect, right? So the doctrine of double effect, it's used in the medical context, and it's also used in the military context. The doctrine justifies certain acts that have a negative effect, but that negative effect can't be what's intended. It can only be what's foreseen, okay? So, for example, let's say you're at war and you want to bomb this armament factory, but you foresee that civilians are going to be killed, right? The doctrine of double effect could justify that act, right? But only because you're not trying to kill the civilians. That's not what you're trying to do, right? So it's foreseen but not intended, okay? So another thing that I would say in response to that is relates to the well-being claim that I made in the beginning, which is that the doctrine of double effect only applies when there is a bad act. It doesn't apply when it's a good act, right? If there's no bad consequence, right? So if you think that death can be in someone's best interest, then you're benefiting them. And so the doctrine of double effect is irrelevant. It only comes into play when there is an evil effect, some bad consequence that comes out of the good effect that you're intending.
So in that case, to dig into this a little bit more, if one of the bases of the right to medical assistance in dying or physician-assisted suicide is that a person still has the capacity to make a decision, the four criteria you're laying out, for decision-making capacity. What are the limits that, if any, that should be placed on the kinds of calculations of well-being that should or should not be honored? One of the things we talked about last night were cases of what's called existential dread, where somebody wants to kill themselves not because of physical suffering, because they anticipate being a burden or for some other reason. And it seemed to me to be the case that there is a sense that some of those cases might be legitimate concerns and not. So I think it might help us to understand more clearly the position you're defending if you lay out kind of what are the conditions that have to be met for those calculations of well-being to be honored and to trigger the right to make that decision. Or is it just we just take the person's word for it no matter what, or are there circumstances where I guess not their autonomy in the technical sense, but where their wishes should be overridden?
Yeah, so I think suffering is subjective. I think what constitutes suffering from one person is going to differ to another person, right? So, ultimately, I do think that it comes down to the patient's subjective assessment. So there's no objective criteria. For instance, like if you're a patient and you say like, look, I just can't. There are things that I love doing in my life. I love living an active life. I was an athlete, played all these sports, but now I can't do any of those things. It causes me great suffering because I can't engage in these activities anymore. There's no really like objective way to determine if this person is telling the truth or not. Like there's no way for a doctor to confirm that, right? Like, so ultimately, I think it really does come down to the person's own judgment. Now, in regards to existential suffering in general, and this is like an important point that I think people should understand, is that is the main reason for seeking assisted suicide in euthanasia. It's existential suffering. Pain, physical pain, is not one of the top 3 reasons generally. It might be like number 5, all right? It's fear of loss of autonomy. That's one. Another is the inability to engage in the activities that you find meaningful. It's another one. Not being a burden is another one. Like those tend to be the top 3, right? So I kind of classify those as existential suffering, and I separate that out from like physical pain. Now, those kind of considerations as a category, I think are completely legitimate. And I think they can justify assisted suicide because it is a type of suffering. And that suffering, I think by definition, lowers your well-being.
And in part, you're wanting to argue that those kind of calculations are almost irrelevant because this is just an act that should not be committed, right? When you're talking about the intrinsic dignity of human beings. But one of the challenges that was brought up, because obviously in a pluralistic society, if you make an explicitly religious argument against that, you can't really expect all of your fellow citizens who are not co-religionists, maybe even not them, to accept that as a basis for such a fundamental policy position. So how would you appeal to secular audiences to make them consider more the notion that life has intrinsic value?
Well, I was a philosophy major as an undergrad and thought a lot about doing this, and I don't think there really is one, as I said before. And I tried to invoke somebody who didn't think so either. His name was Martin Luther King Jr. Mm-hmm. And he changed this culture in foundational ways as a systematic theologian, appealing to deeply theological concepts, right? And so I just sort of reject the premise, I guess, that in order to change a culture, we have to translate this theological, which, by the way, is shared by plenty of other faiths, right? So, for instance, Judaism and Islam also share this basic understanding of the human person. But it's pretty well known that some philosophers try to do a natural law analysis of this, but most of the philosophers that I've engaged, and I've done a lot of work, for instance, on the philosopher Peter Singer, I would just agree that once you reject this theological principle, you end up with something, an anthropology which can't understand why human beings have equality, for instance, because human beings without this understanding are definitely not equal. The only individuals who are equal are persons, and persons are explicitly rational and self-aware creatures, at least in his view and the view of many others. When it comes to that, and by the way, this is in our founding documents, or at least the Declaration, right? We are endowed by our Creator with inalienable rights. That's just a foundational principle. And I've written whole books actually saying once you reject that principle, you lose fundamental human equality as a concept. But as you noted, I went beyond the first principle, right, of violation of human dignity, and talked a lot about unintended consequences and things that you can appeal to as secular in a more secular key, like when we invoke autonomy, when we invoke being a burden on others, enjoyable activities. Suddenly, the disability rights community has a lot to say about this question, right? Because if those are legitimate reasons to kill yourself, and Jason is consistent on this question, he thinks almost any reason would be a legitimate one, I think, if it was considered enough to kill yourself. But those who do not have such a consistent position, who pick and choose and say, well, I can sort of understand if you can't have enjoyable activities anymore, if you are a burden on others, if you're not autonomous, then we can sort of understand why you'd want to kill yourself. Disability rights groups rightly point out that this is devaluing people like us, right? They're saying if people like us have a legitimate reasons to kill ourselves, right? And suddenly we end up with the kinds of things that I was talking about in my remarks. So this is a long answer to your question, but I want to hold fast to say for that first argument, it's got to be a theological argument. But there are other arguments we can make that also appeal beyond those that can't accept that theological principle.
Okay. And let's, at this point, let's open up the discussion to the audience. I don't want to monopolize all of it. So we have, so I saw your hand go up first. So I'll go with you and then you.
Great. I'm an attorney who loves a good constitutional debate. I was raised Catholic and have a condition that would qualify in every state that legalizes medical aid in dying.
In every state?
Every
That
state
has
that's
it.
legalized
Oh,
it.
okay.
Yeah. If it's a theological question, why someone else's theological value should be used to measure whether or not this becomes legal. If it's a moral question, whose moral code do we have to listen to determine if this becomes legal? If it's strictly legal, you're right about the founding documents, certain inalienable rights by our Creator. But people who argued against the Bill of Rights said if we list certain rights, people are going to think down the road that these are the only ones we intended people to have. So they included the Ninth Amendment. Where does that fit in the legal calculus? Because I don't think it should be somebody else's theological value. I don't think it should be somebody else's moral value. If I get beyond the utilitarian point or the existential meaning in my life where I have no quality and I am a burden and I can't do anything that I want to do, whose responsibility is it to make that decision other than mine? And why?
The core, yeah, you can.
Please.
I could imagine somebody who wants to sell themselves into slavery arguing a very similar kind of thing, right? And say, this is a very intimate question about how I think about finances and supporting my family and my own particular situation. I don't think anybody should make a judgment about whether I can do this or not. Who is the government to tell me what I can or can't do in these particular situations? It's just a fact we impose autonomy and we impose a particular vision of the good onto individual autonomy all the time. And I could understand why somebody would say, like, why should a particular theological point of view be imposed on any example? But again, civil rights, the whole civil rights movement was premised on Christian theology. It's just a historical fact. It's also the case that there is no view from nowhere. So Jason has a point of view. He comes from a particular place, right? He's not coming from a sort of neutral place that sort of steps outside of a particular vision of the good. Very often when I do bioethics work, people say, oh, you're a theologian. In fact, when I went on, I was doing a debate with Peter Singer on this in Australia, and he says, are you sure you want to be introduced as a theologian? Should we introduce you as a philosopher, right? To sort of smooth this over and say, like, you know, you're acceptable. I said, no, I want to be introduced as a theologian because all of you, including Peter Singer, obviously have a particular point of view. So a theological point of view should be just as welcome at this kind of conversation, part of the public debate, as a utilitarian point of view, as a deontological point of view, as a care feminist point of view. So I would argue there's no way to step out of any particular point of view to a neutral space. Even the point of view you just articulated very well is a particular point of view. And so I think we all need to have a public debate about these questions, bringing our own point of view, and seeing what kind of arguments win the day.
And then,
I have three very particular situations. They get increasingly hard. I just want to say, I want you to answer whether or not you would object. And the first situation is...
Who's the question to?
First question.
who are you asking the question to?
Both. I want to find
okay.
out whether they both, either or other would, I'm going to ask each one, would you object? And the first one is, if I'm over the age of 72 and I experience a heart attack or another heart failure, then I do not want to be, have medical intervention. Would you object or not?
You're talking about DNR.
Yeah, do not resuscitate.
You're talking about a DNR?
Yeah.
Do not, yeah, if I have a heart attack and I'm over this age of 72 and I do not want to have medical intervention, would you object to that?
No, this is assuming that you have decision-making capacity.
Yeah. Yeah,
Yeah.
I think that's the premise.
Okay.
Are you talking about me personally or what the law should be?
If this were a law, would you object to that law?
Yeah, no.
Okay. Next question. If I'm terminally unable to read a newspaper weather report and tell you what it says, then I want to have euthanasia. For example, if the weather report says it's 25 degrees Fahrenheit and clear, and I couldn't tell you it's cold, would you object if I wanted to have euthanasia at that point, terminally, if I'm terminally unable to do that?
So I would want a little bit more detail. So you're talking about a situation where you have dementia or something like that,
Yes.
right?
Yeah.
Yeah. Okay, so that one I'm not so clear on because I don't know if you're the same person.
What do you mean if you don't know I'm the same person?
Yeah, so some people, they, let's say they get diagnosis for dementia, right? And they saw it in their parents and they don't want to live like that. And so what they have is an advance request for euthanasia, right? They don't want to die right now. They want to die sometime in the future, right? It's like when I get to the point where I can't read the newspaper, where I don't recognize anybody, I want to be euthanized at that point, right? I don't know if you're the same person at that future point of time. That's why I can't give you an answer.
Even if I had it in writing beforehand?
Correct. Yeah, because I don't know if you, so this is like a deep philosophical question. It's the personal identity literature. It's vast literature. I don't have an answer for it. That's why I'm hesitant.
What if I had it in writing and each year I reaffirmed that writing?
Yeah, so right now I have my philosopher hat on, okay? Again, if you are that far gone, I do not know if you're the same person. Now,
I was that person last year.
Yes, but you could not be that person the next day,
Okay.
right? Now, but how bioethics and medicine is practiced, it is assumed that you are the same person.
Okay.
That's why we have advanced directives and living wills.
Okay.
Yeah, first let me say I think this is one reason why it's important to focus on anthropology, which, with all due respect, Jason, doesn't lead us to a question where we ask about whether somebody is the same living animal but could be a different person, right? I think we are coterminous with our existence as Homo sapiens, living members of the species Homo sapiens. But to answer your question, no.
Okay. Last question. I am terminally bedridden and terminally dependent on others for locomotion, and I am terminally unable to independently relieve my bladders and my bowel. Then I want to have euthanasia. Would you object? Again, it's in writing, and I have it validated every year.
Yeah, and you have decision-making capacity at that time too. If the answer is yes, then I don't object.
Okay, very good.
No, but I would say something called palliative sedation, which did not aim at your death, would be legitimate.
Okay. I think we have almost more to agree on than we do to disagree on this. That's my sort of general opinion here. Thank you.
Thank you. I've been favoring this side over here, so actually I want to give somebody a chance on this side.
Yes, so I have two threads that I've kind of wanted to go on. The first one's more about this ground for the intrinsic dignity of the person. It seems to be we can go on more of a secular version of that if we think about it as more of the intrinsic dignity of the person comes from the irreplaceability of the person rather and instead of simply saying, oh, just made in God's image. The second thread I wanted to go on here, and both of you feel free to chime in on either of these threads as appropriate. I'm thinking about Dr. Camosy's third point with physician-assisted suicide being more or less unhelpful. It seems like even if it were morally right or what understood as health care, it seems that people will want it or see it as desirable, and it would lead to more or less people accepting poor decisions of doctors and a decline in quality of healthcare if we accepted it as morally good.
So the coercive power of the slippery slope, right?
What was it? Wait, your third? I don't remember which one your third one was and your fourth one was.
The third one was when it's legalized, it takes on a logic of its own that goes beyond the original intention of the law.
Yeah.
Okay. Were you talking about the third one or the fourth one? Because I thought the fourth one was about it's not the role of the physician.
Fourth one is that it undermines the very notion of what it means to do healthcare in the first place.
Yeah.
It could kind of tie into the fourth as well, but I was thinking more of the third. That's when that point hit me during the opening statement.
Yeah.
Yeah.
Okay.
So how do you respond?
Yeah.
I guess,
So let
to
me.
the slippery slope.
So the slippery slope. That's one of the most common criticisms of assisted suicide, right? So if we legalize it in these exceptional cases, right, for somebody who is old and dying, right, and they're suffering, if we legalize it in those cases, we're going to end up legalizing it in these other cases, right? So, for example, maybe you don't have to be terminally ill anymore, right, and you can qualify. Maybe you're just suffering from a mental illness, and then you can qualify. Maybe you don't even have to be an adult. Maybe you can be a child and qualify for some sort of form of euthanasia, right? So with every criterion that's removed, the gate is kind of expanded. So that's like the slippery slope argument, right? So I can give you like my general response to the slippery slope argument. The slippery slope argument is only a criticism if you think the expansions are unjustified, right? If they're justified, then it's not a slippery slope. It's just a justified expansion. So the question is whether or not you think that is morally justified for people who are not terminal to qualify. That's one. Do you think it's justified for people who are not suffering from any physical condition to qualify? What if it's only a mental illness, right? So those would be the questions. And in general, I don't think that you have to be terminal to qualify. So I think that it comes down to, again, autonomy and well-being, right? And the fact that you're terminal doesn't determine that in one way or the other. Right? Like, I don't think it's relevant for that. So, for example, like you can have ALS and live for a long time, but it causes you a lot of suffering. So the fact that it's not terminal actually causes you more suffering, right? Because you're living a longer time with that condition. Also, when it comes to autonomy, I don't think that you need to be terminally ill to refuse medical care, right? You don't have to be terminal to refuse life-saving medical care, right? So let's say that Jehovah's Witnesses, they have a right to refuse blood products, right? They're not terminal, right, because you could save them, right? But they can refuse, even if you think that their beliefs are completely wrong and false and bonkers. Doesn't matter. You have to respect it, right? In regards to the fourth one, the physician-assisted suicide is not within the role of the physician. So I'm actually okay with that, right? So a couple of responses. So one is that there were other procedures that doctors already performed that actually don't fit into the criteria of healing. So one is cosmetic surgery, right? So you perform these surgeries just for aesthetic reasons. That's one. The other one is vasectomies, right? So the purpose is to prevent unwanted paternity. It's not to heal anything, right? So now the response may be, well, doctors actually should not perform those things, right? Because it's not part of the healing profession. Okay, that's fine, right? I'm okay with that. I'm also okay with the non-medical model, right, of assisted suicide. Almost every jurisdiction that legalizes assisted suicide is a medical model, meaning that you have to talk to doctors, right? A doctor has to approve and to assess you to see if you satisfy the conditions, right? I'm actually okay with there being a separate system involved so that we actually leave doctors out of it, so doctors don't have to participate. Right? So Switzerland has more of a non-medical model, right? So you don't actually have to be, you don't actually have to seek the assistance of a doctor to get an assisted suicide.
What are the institutional arrangements in Switzerland for that if it's not
So
consulting a doctor?
I don't remember exactly what the law says. So basically, the person who's assisting you can't be doing it for selfish reasons. It's pretty liberal. I mean, they have organizations that do it, like the Dignitas and Pegasus and stuff like that. Yeah, you don't, and they do have doctors who work at those clinics, but I believe they're not, when they're working there, they're not working there as a doctor.
Okay.
I think. So there's some technical
Like a
way
consultant.
that they're making that distinction. So I don't know if you knew this, but I'm going to bring up Philip Nietzsche again because this guy's really interesting. So Philip Nietzsche is basically the modern day Kevorkian, okay? Except he's Australian and he lives in the Netherlands. He's famous because he created what's called the Sarco, okay? Which is a 3D printable suicide pod. It's like a capsule that you climb into. It closes and it fills up with gas, and then you die, okay? The purpose is to end your life. Sarco is short for sarcophagus, just so you know, okay? So he invented this thing, right? It was used for the first time last year by an American woman in Switzerland. She died in some forest. Yeah. But anyway, they did it there because you're allowed to do it there, right? Like, you don't have to have a doctor help you do it. It could be just be a technician.
So if it's okay, I'd like to go through all three of these topics.
Yeah.
So,
But just quickly though, so we can make room for a few more people to ask
okay,
questions.
because there was a lot said here.
Yeah.
It's important stuff.
It is.
So I love Jason's consistency on these questions because he's willing to bite the bullet and take it where it goes. That's one of the reasons I really admired Peter Singer, did a lot of work on him. He's a very similar kind of thing. If I would actually support moving this away from medicine because I think it's corrupting medicine, it's imagining medicine as something other than what it is intrinsically for, as the American Medical Association suggested. I also think doctors should not participate in the death penalty, right? That should be another thing that is obviously antithetical to the ends of medicine. Let me go back to the slippery slope thing. Another thing that Jason admitted very consistently, he's fine with this going wherever it goes. The slippery slope is not bad. For many people, however, it is bad, and I think it's worth noting that this is what we've seen in Canada, it's what we've seen in the Netherlands, not necessarily in the United States yet. One of the reasons for that is because Compassion Choices, used to be Hemlock Society, actually lobbies against any expansion of assisted suicide because they don't want people like me making arguments in venues like this saying, look at what happened in California. So for instance, California tried to expand, a legislator there tried to expand physician-assisted suicide to include people with dementia, and Compassion Choices, the most important lobby organization for PAS, shot it down, said we're not going to do this right now. And then finally, the question about intrinsic dignity. Did you say unrepeatableness? Was that your point?
Yeah, unrepeatability or predictability, if you're familiar with the work of some of the personal philosophers.
Yeah, I guess I just don't understand why I wouldn't say the same thing about my dog. Do you?
Well, what I'd say there is that with your dog, you've essentially given that irreplaceability to that particular dog, but dogs in themselves don't have the same level of irreplaceability that we do.
All right.
You're warming off the dog in the same way that I'm warming off with you.
Just last thing, reductionists say the same thing about human beings, though, right? We just impute this onto human beings.
Wait, so it's the view that like one golden retriever is just like any other golden retriever?
In a sense, but it's like with the case of with the case of pets, is that we would still mourn that golden retriever's loss, but not as much as we would the loss of my brother or son.
Yeah, but I just don't know if that hinges on the irreplaceability component. It might be something else that's doing the work there.
Okay. Sir, did you still have a question?
I'd like to ask
but if a woman would like to take my place, we've only heard from men. I know that's what my mother would want me to do. So
I saw, now a while back I saw a hand over there, but I saw a hand here too, so you did still have, yeah, and then ma'am, right there, yes? Ashley, did you have your hand up? Yeah, okay, so but first.
Okay. I am a retired healthcare provider, and I tend to look at this stuff kind of more practical rather than theoretical. I know here we're kind of talking about on a theoretical level.
No, we both work
mostly.
in clinics, so we're happy to talk
Are
about
you?
clinical stuff.
So, but when you're talking about dementia, because I have a situation, there's a friend who wants to, at the point that she doesn't recognize anyone, you know, can't eat, has to be fed, that kind of stuff. But to me, a practical way to do it is have them sign that, maybe review it every year, but have them identify one person that the healthcare people have to talk to in order to carry out her wishes. Because to me, that's representing her autonomous decisions and her wanting to maintain her dignity, because someone who has really advanced dementia it is not a dignified way to live.
So I guess I'm going to respond to that. Oh, just to clarify, I no longer work for a hospital. Okay, I work on the university site. I teach. So I hear what you're saying, and so I completely agree. And I think that the way that I would put it is that it's extremely important to have a healthcare power of attorney, right? So a healthcare power of attorney is a legal document that allows you to appoint someone as your healthcare agent or attorney in fact, and that person is going to be your surrogate decision maker. Right? So you're talking about like, well, let's have someone kind of speak on behalf of this patient, right? Somebody who knows the values of this patient to advocate for them when they've, you know, when they have dementia. Yeah, completely agree. You should have a healthcare power of attorney.
As somebody who taught in a medical school the last 3 years, I'll just say, I think what you're talking about would work out practically speaking, but I of course reject the premise, right? And many, especially disability rights groups, reject the premise. They would say our lives have dignity not because of whether we can go to the bathroom on command or whether we can hold our bowels or whether we know our names. We have dignity as intrinsic human beings who have the same natures and nothing else, right? And so it's interesting how the word dignity is used in these contexts, right? That's why it's so important to pay attention to language. Death with dignity, an undignified life, but also dignity used in a quite different sense. The sense I'm using it, the way disability rights group use it, is to say it's a category error to think of human beings having dignity based on these accidental traits. And once you open the door, some of you may in fact agree with her claim, but once you open the door to saying you don't have intrinsic dignity, you have dignity based on X, Y, Z traits, we can go back to a time where we had the baby doe case. Maybe some of you are familiar with that. That's some people point that case at the beginning of contemporary secularized bioethics in the 80s. There was a baby born with Down syndrome, also had esophageal atresia. It was a very simple surgery to fix the atresia. The medical team and the parents decided not to fix the atresia simply because the child had Down syndrome. Now that seems maybe unthinkable today, but once you open the door to saying it's not because of your intrinsic humanity, right, but of these other things that matter, you open the door to those kind of judgments.
So I kind of want to respond to that. So this is a common objection from the opponents of assisted suicide. The way that I will push back against that is this. I am not really making a judgment on your quality of life or the value of your life, right?
You're not. I'm responding to her.
Yeah, right. So that's the way that I would say it. Like, it's up to you, right? So I'm not saying that a life in a wheelchair is not worth living. That's not what I believe, right? I'm saying that you should have the right to determine that for yourself. Suffering is subjective, right? I don't have to approve of that. It's not up to me, right? Again, it's not, whose body is it? I think that's one of the fundamental questions. Does your body belong to me, or does your body belong to the state? Or does it belong to you? If it belongs to you, you should have the right to hasten your own death, right? If it belongs to the state, then the state can prevent you from doing that because it owns you in that sense.
The state, restricts the bodily autonomy all the time.
Yeah, so then we can have a conversation about like more like libertarianism, about like how vast and how invasive the state should be, right? Because you do have like more libertarian folks who really think that the government should shrink and shouldn't prevent us
But
from
the reason
doing a
I
bunch of
mention it is
things.
because it doesn't follow that just because the state can restrict your autonomy, that the state owns your body.
Yeah, and I'm speaking a little metaphorically here too, because I don't actually think that your body is literal property. So I don't think that you can own your body like you can a laptop, right? There's some metaphysical disanalogies there. For instance, like I can alienate myself from my laptop, right? I can sell it to you and then I can kind of give it to you, right? Can't really do that with like me and my body, right? We're very intrinsically intertwined with our bodies. Some people think that we are our bodies, you know? So it's something that's close to property, but not literal property because of those disanalogies.
In a somewhat metaphorical sense, the idea that you are the one that should have control, subject to certain limitations, you're the one that should have control over what happens to it, and you believe that the decision to commit suicide falls within the scope of what should be permitted.
So just think of like other self-harmful activities, right? Like, should you have a right to smoke? You know it's bad for you, right? Should the state prevent you from doing that because it's bad for you? Like, so if you're in favor of the state intervening, then you're more on the paternalism side, right? So the state is kind of like your parent and you are the child. And just like how we force our children to do certain things for their own good, the government is justified in forcing us to do certain things or preventing us from doing things for our own good, like preventing us from smoking, right? So it depends on like where on the spectrum that you fall. I think that you do have a right to smoke. I think you have a right to eat junk food, right? You have a right to make poor decisions because it's your body.
Okay, now, and then I will come back to you, Sarah, since you so graciously.
Yeah, that was so nice of you. So, another great evening. And as I said last night, I just kept thinking about how tied all of this debate is to sort of Enlightenment decisions about shifting language to autonomy. And, I voiced my concerns about that, although not so much from a Judeo-Christian standpoint, but from another one. Tonight, I'm trying to work out this challenge of like a secular grounding in suffering, and whether we could take this almost in a quasi-Nietzschean direction, and that we deprive people of the self-overcoming of suffering. That you don't even have to like appeal to a higher power to have had the experience of the sometimes some of the most important shifts for us developmentally are a direct result of having to encounter suffering and the edges of the suffering and the overcoming. So I just wanted to hear your thoughts. That's as much as I have right now, but I've been very intrigued about thinking about also that possibility.
So kind of questioning that, in a way you're saying that part of the premise of this discussion so far has been that suffering's bad, and you're raising the question of whether we should think of suffering as bad, or maybe also there are times when it's, yeah.
You're asking for what a secular conception of suffering would be? Or is that not what you're asking?
Well, we were talking about whether we just appeal to the dignity of the individual only in a Judeo-Christian like tradition. So is that the only appeal? And so I was thinking, well, what if we ground it just in sort of a kind of Nietzschean direction of the self-overcoming in suffering and what that opens without having to make an appeal to a deity for a sense of dignity?
I'm not sure.
Yeah, it's hard for me to answer because I did not, my invoking of a theological perspective didn't invoke suffering, so it wasn't an argument that I explicitly made, so I think that's a question for you.
No.
Well,
I'm still not entirely sure. I'm still not entirely sure what the question is. You're trying to say maybe there's some secular way to ground this notion of intrinsic dignity of a human being,
Despite suffering.
Yeah.
No, I think what she's asking is there a way to say suffering has a value that we ought to have in the culture, maybe in a Nietzschean way that says people should be given the opportunity to overcome their suffering instead of appeal to different alternatives to escape it, if that's...
Yeah,
And yeah.
Okay, sure,
Yeah.
sorry. Yeah. So I also think it could be compatible with like maybe a Buddhist standpoint to orientation of the elimination of suffering as the quieting of suffering as very important to the task of being human.
Okay, so I'm going to try to understand your question here. So you're saying maybe there's a way to see suffering not just as a bad thing, right?
Yeah.
That it's not just a disvalue, but there can be value to suffering.
Yeah.
I think there's truth to that, because I think that we can grow from suffering, right? But then when you have such a possibility, it doesn't mean that that's going to happen, right? So and that kind of gets into this like limitation of like our abilities to know the future, right? So let's say that you have this person who is seeking assisted suicide, and typical case is that they have cancer. That's probably the most common case, right? Is this person going to gain overall from their suffering or not, right? Maybe. I think the only thing that we can operate with is reasonable expectations, right? What does the progression of this cancer look like? We have that type of data. What do you care about in your life? The patient has that data, okay? And then try your best to kind of analyze both sets of data and see how you're going to respond. And that's the only thing that you can do in regards to refusing care, right? So here I'm going to jump back and forth, right? You could say the same thing about refusing care. Maybe we should prevent people from refusing life-saving care, because like, you know what? Suffering's good for you. Did you know that you can transcend your suffering? Right?
So
That's why we're going to prevent that.
It comes down again to the idea that these are either judgment you might think is valid, but it should be left to the person to make the judgment about
Yeah, it should be left to
that.
the person,
Yeah.
and I think we should be consistent when it comes to refusing life-saving care and assisted suicide.
Okay, and so one more question, thanks. We're actually running a little bit over time, but please wait for the microphone so that the world can hear you.
Kind of a different way to look at this issue. I want to talk a little bit about the politics of it. You had mentioned earlier that this is not a right and left issue, which I sort of agree with in terms of the left of center people in our country. Yes, there's a split. I do not agree with you that there's a split on the right of center, at least the leadership.
Oh, there absolutely is.
There isn't, or there is?
There is. Libertarians and small government people love assisted suicide.
Other than Montana, which is a completely unique situation for assisted suicide, and maybe a handful of people in New Hampshire because they have so many state representatives, can you name one elected official in a red state that has publicly either voted for or come out in favor of physician-assisted suicide?
No, but if you give me 5 minutes afterwards, we can Google it together.
Okay.
Yeah.
One last thing. Your friend's request, I don't know if you know what my hockey jersey is. It is legal in the province of Quebec, what your friend wants. Something to look into.
Okay, so at this point, each of our speakers is going to have 5 minutes to give a closing statement. And again, the challenger to the status quo will get to have the last word, just as they got the first word.
Again, I want to say just how good it is we are doing this together. This is a important thing to do, and especially at this moment of our culture, especially with our politics the way it is. And somebody mentioned that there's more agreement here than maybe we expected, and I think that's definitely true. So let me just begin by reviewing a bunch of the 4 arguments that I made in the beginning, because I think that might be helpful. The first one is the only one, at least that I think of, that is, and I'm not apologizing for it this way, because I've been confident, as I hope has been clear, but it's the only one that really relies on a theological premise, that PAS violates the intrinsic dignity of the human person. All the others are something that I think we can speak of across theological differences. PAS helps shift our understanding of what lives are valuable and which lives are worthy of protection and public support, especially in the face of scarce resources, which puts the most vulnerable at risk. I think this is especially a problem. More than one time we've heard dementia here. I think the more that we devalue the lives of those with dementia, this will come up as a very important thing. And again, California has already tried to legalize this, and it will eventually. I think most states will eventually, if we continue on the current path. PAS, when legalized, takes on a logic of its own that goes well beyond the original intention. And then when it's understood as healthcare, it undermines the very nature of any coherent understanding of the practice or profession of medicine in a way that's very similar to the death penalty. So I want to finish with some images that highlight a yes. So I've been focused on no's, and I don't like to focus on no's. I think especially in a Catholic key, there's too much focus on no's and not enough focus on the bigger yes. In a truly theological perspective, the yes is far more important than the no's. So let's focus on some of the yeses. The yes is to elder justice. The yes is to disability rights. The yes is to care and concern for the most vulnerable. One of the things, I spent 14 years teaching at Fordham University in the Bronx and taught a bioethics course, service learning, in which a bunch of my students were able to do service learning at Calvary Hospital in the Bronx. And what Calvary was famous for was the fact that no one who went there ever requested physician-assisted killing. They all felt taken care of. They all felt that they weren't a burden on others. They felt like they did have enjoyable activities, and they didn't mind that they were losing their autonomy because they were in a loving community of people. We need to recreate those loving communities of people. That's how we respond with a bigger yes. I don't know if you can see the image on the upper right. That's an image from something called Glenner Town Square. It's a drop-in center for people with dementia and other memory issues. It looks like the 1950s, right? You know why it looks like the 1950s? Because that's the decade a lot of their residents remember. Isn't that beautiful? We need a lot more Glenner Town Squares. I've been arguing to a few leaders and bishops in my community. We have all these empty school buildings and convents and rectories. We should do something like this as part of our response. So it's not just a no, but a yes. This image here is the Los Angeles Carmelites, who host a number of facilities for people in various stages of need at the end of their lives. This is an image, I don't know if you can see. Here's a glass of wine. Here's a glass of wine. This is called Vespers and Vino. For those of you that know anything about the Catholic tradition, they have Vespers and Vino. What a beautiful way of being a community of people, right? That person is not autonomous, right? That person has lost many individual things they used to consider valuable. But that person is happy. That person is flourishing. That person is in a loving community. I'd also point out this image here. This is from a institution in Minneapolis that has both child care and elder care in the same building. So on the ground floor is the child care. On the upper floors are the elder care. It's intergenerational care. What an unbelievably beautiful model. I think that's also something we ought to think about. Far too often we push people out, especially our elders, out into the recesses of the community, and then to give them the choice, right, to kill themselves, the coerced choice to kill themselves. This is the kind of creative thinking we need to think about the broader yes. And let me just finish by saying so many people would rather die at home than in a clinical context, and we don't do nearly enough dying at home. My father, on July 31st, just died in his home. It was a beautiful thing in some ways for that to happen, right, surrounded by his pets, his children, his wife. It's also, by the way, for your libertarian small government people out there, far less expensive for this kind of care. And so let's talk about the bigger, broader yes rather than just the no. That's where I want to leave you.
And you can pace again.
I can
if you
pace again.
want
Okay,
to.
I was just about to ask you.
Yeah. You're
Yeah,
free to
so
move about the. Yeah.
I really like that ending. I would agree that we should do all those things, but I would also add that we should allow assisted suicide. Again, I'm okay with the non-medical model. We can figure that out, right? So I wanted to address two things that I didn't have time to address earlier. One is suicide prevention, the juxtaposition for that and assisted suicide, right? And the other is this concept of intrinsic dignity of human beings. So, first one. If I saw somebody about to jump off a bridge, I would stop them as well. And that's because I don't know if that person actually wants to die. I don't know if that person has decision-making capacity. So that's a different situation, right? So you have suicide prevention for some folks, and you have assisted suicide for other folks because of the two different groups of people, right? And you could shift to the other one, right? Let's say at first you didn't actually want to die, but then after a while something else happens in your life, and then you actually do want to die, and you have decision-making capacity. I think then you would shift from the first group to the second group, right? But they're generally two different groups, okay? So in regards to the intrinsic dignity of human beings, again, I understand it in terms of intrinsic value. I think it's probably an intuitive way to think about it. Of course, I'm not religious, so I can't approach it from a theological perspective. But I think there is some maybe secular version of it. I don't know how to ground it, but I think a lot of people who aren't religious probably do find it somewhat intuitive, okay? So let's say that it's a legitimate value, okay? And I do think it is. What I would say in response is that this is why we care about your autonomy and your well-being, right? If you didn't matter, if you didn't have intrinsic value, why would we care about what you want? Why would we care about your well-being, right? If you suffered, if you didn't have value, you could suffer and it wouldn't matter to anybody else, right? But the fact is that we care. We care about your autonomous wishes being honored, your end-of-life wishes being honored, and we care about the fact that you suffer because we don't want you to suffer, right? So I guess in that way, having assisted suicide does honor the intrinsic value of human beings. Yeah, that's it. Thank you. Oop.
Thank you. Yes, please, before we conclude, I do want to express my gratitude to both of you for taking part in this and to all of you for being here. I wanted to thank a few other people, the students, faculty, staff, colleagues who've made tonight possible, and also especially to Nick Kulik of the Foundation for making the venue available to us. I wanted to mention that I hope to see all of you at our next event. Our next public event will be November 13th. We'll be welcoming Dr. Nasser Hussain, the Associate Director of Civic Life and Thought at Duke University. He'll be delivering a public lecture entitled American Taboos, Teaching the Unspeakable in Higher Education. So this talk will be on the University of Toledo campus at noon on November 13th, so please sign up for a newsletter for more information. You can go to utoledo.edu/institute/constitution. I think tonight's discussion really exemplifies what our Institute of American Constitutional Thought and Leadership was established to do, to create spaces for reasoned dialogue about questions that matter deeply to our common life, where disagreement can coexist with mutual respect, which our two speakers so excellently modeled tonight. So on behalf of the Institute, I'd like to thank you again for joining us for this debate, and please join me in one more round of applause for Drs. Camosy and Chen. Thank you. Thank you very much.
I wasn't clapping for me, I was clapping for everybody.